Welcome to The Explainer. Today, we're unpacking a really fascinating slice of medical history. We are looking at Samuel Hahnemann's intricate framework for classifying diseases, straight from his foundational text, the Organon of Medicine. Now, whether you're already well-versed in homeopathy or you're just curious about historical clinical structures, we're going to be mapping out exactly how this system categorizes the very nature of human illness.
So how does a homeopathic actually know exactly where to begin? That's a great question, right? When a patient walks into a clinic presenting this complex web of symptoms, how does a practitioner using this specific historical philosophy structure their initial clinical strategy? Well, they don't just jump straight to picking a remedy. Instead, they rely on a highly structured taxonomy. It's essentially a massive decision tree that helps them figure out exactly what kind of illness they are dealing with before they do anything else.
Okay, let's dive into this taxonomy tree. Here's our map for today. First, we'll look at the split between acute and chronic disease. Second, the three types of acute disease. Third, unlocking the genus Epidemicus. Fourth, the roots of chronic disease. And finally, indispositions and mixed cases.
All right, starting right at the trunk of our tree with Section 1, Acute versus Chronic Disease, the baseline split.
According to Aphorism 72, the very first step is separating short-lived dynamic disturbances from deep-seated progressive illnesses. Acute diseases are characterized by a sudden onset, a rapid pace, and a self-limiting course that naturally terminates in either recovery or, historically speaking, death. You contrast this with chronic diseases. These develop gradually, they progress over time, and they deeply involve what are called maintaining causes, basically ongoing factors that keep the illness locked right into place.
Now, you might think duration alone is enough to classify an illness, but it's really not. Practitioners actually evaluate 4 clinical dimensions to build their hypothesis. First, they look at the onset. Was it sudden or gradual? Then they evaluate duration. Is it short, persistent, or maybe recurrent? Third, they identify the cause, searching for a sudden, exciting trigger like freezing rain, or a maintaining cause like living in a damp house. And finally, the course. Is this thing self-limited, relapsing, or is it steadily progressive?
Moving right along to Section 2, three types of acute disease, categorizing short-term illness.
Now, what's really interesting here is how Aphorism 73 beautifully organizes these sudden illnesses based purely on their scale and their triggers. Because acute disease isn't just a monolith. Individual acute affects a single patient, often driven by personal triggers like overeating or an emotional shock. Scaling up from that, sporadic acute affects a few isolated cases simultaneously in one locality, usually triggered by local weather. And finally, epidemic acute sweeps across a large population with uniform symptoms, and that's driven by contagions or massive environmental disasters.
Let's put this into perspective with a quick micro-narrative to see what an epidemic acute disease actually looks like in practice. Imagine a real-world medical detective scenario. A sudden flood hits a village. Shortly after, 40 villagers present with the exact same symptom picture. We're talking high fever, severe body aches, extreme anxiety, and a highly specific thirst for cold water. Because of the scale, the shared environmental disaster, and that uniform presentation, a homeopathic practitioner immediately classifies this not as 40 individual diseases, but as a single epidemic acute event.
And that brings us perfectly to Section 3, Unlocking the Genus Epidemics, Finding the Collective Pattern.
Normally, in a standard consultation, a homeopath is famously hyper-focused on the highly idiosyncratic traits of a single patient. But during an epidemic, the strategy flips completely. Enter the genus Epidemicus. This is a unique historical term for a single remedy identified not from one person, but from the collective totality of symptoms across multiple patients. The focus shifts entirely away from the individual to a unified community symptom picture.
Building that community remedy profile is actually a very rigorous 5-step detective process. Step 1. The practitioner collects several complete cases from the outbreak. Step 2. They compare them to find highly characteristic features, like that specific thirst for cold water we mentioned earlier. Step 3. They exclude the incidental symptoms that are just unique to single patients. Step 4. They synthesize the remaining data into a collective totality, which is essentially treating the entire epidemic as one giant patient. And finally, Step 5. They verify this genus Epidemicus by checking if it accurately fits new cases as they emerge.
Pivoting away from rapid outbreaks, let's look at Section 4, the roots of chronic disease, understanding lasting illness. When classifying an illness as chronic, the practitioner absolutely cannot just look at a snapshot of today's symptoms. As the source material strictly dictates, chronic diseases develop gradually, meaning the patient's history must be understood longitudinally. Practitioners have to evaluate the entire lifespan. They look at the baseline health before the onset, the sequence of recurrences, and exactly how the disease has evolved over the years.
Hahnemann actually separated chronic illness into two very distinct camps. First, you have true chronic disease. This is a natural illness driven by an underlying persistent pathology, historically termed miasms, which were proposed to explain these deep-seated susceptibilities. On the other hand, you have artificial chronic disease, which is entirely different. This state is driven by prolonged exposure to external substances or repeated aggressive medical treatments that actually alter the patient's baseline. To treat either of these types effectively, modern interpretations of the text require removing what are called obstacles to cure across 4 levels of maintaining causes. You have biological factors like an untreated hormonal disorder, behavioral factors like smoking, environmental risks like occupational chemical exposure, and crucially, social factors like chronic caregiving stress or food insecurity. The core idea here is that if these maintaining causes aren't modified, the chronic disease simply cannot be resolved.
And finally, we arrive at our last branch of the map, Section 5, Indispositions and Mixed Cases, Distinguishing False Alarms.
So, Aphorism 150 actually warns practitioners not to overinterpret every little ache and pain. This introduces the concept of an indisposition, a minor, transient disturbance with a very clear situational cause. Think of getting a headache from a really bad night of sleep or digestive upset from overeating. It has very sparse symptoms and it just resolves on its own once the cause is corrected. It's essentially a false alarm, definitely not a deep constitutional disease.
Now, this is absolutely crucial. Ultimately, this entire highly philosophical system is anchored by a very pragmatic safety-first protocol. Whether a practitioner is dealing with a massive epidemic or a simple indisposition, they must immediately assess for life-threatening red flags. Urgent conventional care is absolutely required for issues like severe breathing trouble, altered consciousness, or suspected sepsis. Homeopathic assessment, according to modern interpretations of these guidelines, should never delay necessary conventional medical triage.
So what does this all mean? We've mapped out a highly organized historical system that categorizes illness not just by giving it a name, but by looking at how it moves through time, how it impacts a whole community, and how it is sustained by a patient's everyday lifestyle and environment. So I leave you with this final thought to chew on. If we were to rigorously evaluate every illness through its onset, duration, cause, and course, how might viewing the whole patient timeline fundamentally change our overall perspective on health and disease? It certainly challenges the way we think about the narrative of our own well-being. Thanks for joining me on this explainer, and keep asking great questions.